Okay, so in the next minutes, I'm going to talk about innovations in clinical management of glaucoma. And for the purpose of the presentation, I think it would be very nice to know what is innovation. So basically, innovation is the action or process to do something in a new way or have new ideas about how something can be done. But I like this second definition better, which is actually turning an idea into a solution that adds value. And if we are talking about clinical innovation, that necessarily needs to have a clinically application or a clinical application. Okay, so this will be the outline of my presentation. I will talk about structure, about new things in function, about how structure and function relate, about how can we assess progression, and finally a couple of slides about new technologies, especially OCT and geography. So let's go for structure. So now with OCT, we can do a global evaluation of glaucoma, a complete evaluation, and that's very important. We know that glaucoma happens at the optic nerve head, especially at the neuroretinal rim, in which we can see mainly the retinal ganglion cells axons. That's how we can actually see it in a high definition OCT. Then the axons of these cells go to the retinal nerve fiber layer. The soma of these axons are what we talk, or what we say the ganglion cell layer. And finally, the dendrites make one layer that's called the internal plexiform layer, or IPL. So OCT can assess each of these separate entities in a way that we can have a complete evaluation of the neuropathy. So we can see the rim, and we have the analysis of the area of the rim, disc, volume. Then we can assess the peripapillary retinal nerve fiber layer of these axons at the surroundings of the disc. And then at the end, we can see also the ganglion cell and EPL layer all together to have an idea of what happens in this location as well. These parameters have some strengths and some limitations, each of them. So for the rim, we will have first an idea of how the optic disc looks like, and we know that cupping is a very strong characteristic for glaucoma. Actually, this is what we will look most of the times clinically. It will be very helpful for us to detect asymmetry. And sometimes it has been said in some studies that it could be also a better parameter in discs that are not completely into normal limits and that are tilted. The other very important parameter, and is the one more widespreadly used, is the peripapillary retinal nerve fiber layer. It will be able to change even 4 years before the actual damage appears in the visual field. It's very good parameter. It's not been overcome by any other parameter yet, and it has a very good discriminative ability. It's very useful in early stages, in mild to moderate glaucoma, and the better parameters that we have is the average thickness parameter and the inferior region thickness. And the last but not least would be the ganglion cell layer that, remember, in the serous, we measure it together with the IPL. This parameter has been shown to be very sensitive, especially in suspects or in ocular hypertensives. The parameter that changed first is the GC IPL minimum. It's very good detecting focal damage or paracentral defects that are very characteristic of normal tension glaucoma. But because it's the end of the neuropathy is where the soma is, we also always need to look for a certain sense with the optic disc appearance. And the shape that it characteristically has, it has been called as a snail shell appearance, like you can see here in the screen. And it's also been useful as a complementary information when we see a tilted disc. And now the innovation in the latest studies is that what we have to do is not use one of these parameters alone, but combine them. That will lead to better outcomes, and current evidence suggests that using all together will enhance the sensitivity to diagnose glaucoma. So that's what we have to do. And I have some examples for you in which you will see that all the parameters need to be assessed as a whole. So here we have a 70-year-old male that we've been following for some years with ocular hypertension. He has a African descent that we know that this is a risk factor for glaucoma. And currently his IUP is 22. And we are thinking, well, should we treat? Should we still look just for changes? Whatever. We see these tests. And actually in the field, we see some inferior defects that almost here in the pattern deviation could be almost like a incomplete arcuate defect, but very mild. But it all makes sense. If you take a look at the disc, here we can see an inferior borderline situation, which will match with this superior zone that is also here and here. And also there are some mild changes in the ganglion cell layer as well. So if you have these three things and the pressure is not perfect, and then we also have the risk factor of being an African descent, I would probably treat this patient. And that's why we need to take all this together, because only with the field, maybe we won't be sure. Only with the optic disc, we possibly won't be sure. But when we see all together with the macula as well, then we will decide to treat. This is another patient. She's a 69-year-old female. She has an untreated IUP of 14, which is statistically into normal limits. And we were thinking, this is glaucoma or not? We see this field that has some changes here inferiorly, but they are very paracentral. We won't be very sure. And you know, the optic disc that looks not too cupped, maybe here a little notch. The peripapillary retinal nerve fiber layer is completely normal. Maybe if we see the hour clock sectors, maybe there's a borderline change, which we know it has high variability. So we typically not always listen to this. But when we take a look to the macula, we see this sign. This is also called the Raffi sign because it respects the Raffi area. And if we take a closer look to the macula, we see this snail shell appearance that I was talking about. And you know, this change is basically superior, and those paracentral defects are inferior. So yes, this is glaucoma, and it's probably a normal tension glaucoma. And I have one more example. So this is a patient referred to us because they think it could be a glaucoma suspect. He has 22 millimeters of mercury of IOP, and we see this structure. So the nerve, again, the head of the nerve doesn't look bad. We see all between normal limits and symmetric, apparently not notches, rim looks good. Then the disc, the peripapillary retinal nerve fiber layer, again, it's between normal limits, both eyes. But when we look at the macula, the ganglion cell layer, what we see is something that's not very typical of glaucoma, which is a vertical respect. That is not glaucoma. Glaucoma doesn't go vertical, it goes horizontal. And if we do the fields, what we see is that the field actually looks exactly like the damage that we are seeing at the macula. So that's what I was saying, that it has to make sense with the optic disappearance. So if you have a very bad ganglion cell layer, very affected, you should have a very cupped disc, or at least some cupping. Otherwise, it's not glaucoma, or at least you have to look for something else just in case it's not glaucoma. And in this particular case, this patient had a cerebrovascular accident, a stroke. Okay, so next we'll go to function. And the new things in function go with the idea that sometimes 24-2 standard automated perimetry is not able to completely represent all the certain patterns of damage that glaucoma has. So we know that for each 3 decibels of visual field loss, a pretty important amount of retinal ganglion cells are lost. In case that this damage is peripheral, about 30 to 40% of cells are lost. In case this is central, more than 50, up to 70% retinal ganglion cells are lost. And we know that these 4 points here, by a lot of words, especially by this work of, Donald Hood, we know that macula is underrepresented with the 24-2. So in these cases in which we are suspecting a paracentral defect, we should do 10-2 better. So more and more studies are telling us to include somehow, or not in all, but at least in some of them, 10-2 as well. And I'm going to show you an example about this. So this is a 50-year-old female. She has a cup disc. Her pressure is 16. In the nerve, you can see here an important inferior temporal notch, very characteristic of glaucoma. This is a normal pressure. This is untreated pressure. And these are the tests we were talking about. Here we can see how the disc matches to the appearance. The peripapillary nerve matches to the appearance of the disc. Is this inferior defect? Also, we can see here in the macula that we have also this inferior defect that matches possibly with these little points, but you know, these are could be in a specific, we're not sure. If we do a 10-2 in these cases, we can see how this central defect is actually not that small. And these are the 10 degrees central, and it has a very close to fixation damage. So 10-2 is important to characterize pericentral defects. In this line, we will now have a new strategy that's called the SITA-Faster 24-2C that tries to integrate 24-2 and 10-2 together. So on top of the 24-2, 54 points, it combines with 10 selected 10-2 points, those who have shown to be more specific detecting damage, and they do it all together in the same test. I have not examples for you about this yet, but we just got the software, and I'm excited to start doing this because it will probably save time to my patients. So next innovation would be, what are the new trends in structure and function relationship? So we know that structure and function do not always go together. Sometimes they do, sometimes they don't. But we still know, and there are some patterns that we can have as a help or as a tip. So what we know is that in early glaucoma, like in here, in which the thickness is still very good at the beginning of the neuropathy, the structure changed earlier, and it's very good detecting damage. You can see in green the structure, in blue the function. So structure change first. That means that OCT has more value in early stages of glaucoma. If we go at the end of the neuropathy, right to the other side, and this is a very nice work of Felipe Medeiros that I always use in my presentations because it's very helpful to understand that in these cases, then it happens the opposite, because the OCT has a floor effect and it arrives at a certain point in which it cannot lose more. Then in those cases, possibly visual field gives us more information. And then there's a middle situation, like in mild to moderate glaucoma, that structure and function go together a little better. They are more correlated. So in these cases, possibly structure and function go easily together, and it's easier to understand. But that's why we sometimes find things that don't match. The other important new thing that I think we should use in our patients, or it has been helping me a lot, is how to assess progression. Because, you know, glaucoma is a progressive disease, and that's what it's very characteristic of the condition, and what it makes it different about this condition and other things. And it's important to evaluate both structure and function over time. And in my opinion, trend analysis is the more important. The other could give us information, but evaluating linearly trends is more intuitive and more simple. And actually, it's able to detect most of the eyes that basically would later have a clinically significant progression. And I'll go through this a little bit later, because clinical significant progression is a very important concept. And it has also been shown that trend analysis is the most important parameter to actually start treatment or change treatment. But have in mind that it's important to have enough tests to have a good rate of progression. At least 5 tests in 2 years is what it's more recommended. We'll do first function over time. As I said, trend analysis is the one I think is more important, but we also have event analysis that will help us with focal change. And now with the current softwares, we can do trends with visual field index and also with the mean deviation of the Humphrey visual field. Remember that in this analysis, age is always incorporated. So our idea, if we want to have zero progression, is to have a flat curve, no slope. If we have slope, that means that this patient is progressing at a greater extent than what it would be supposed for him for a certain age. And again, this concept of rate of progression that we can have also with these progression analysis that are really helpful. But the big question is, what rates then of progression are clinically relevant? So what we know is that there's a certain amount of progression that's really too much. It's what we call fast progressors. And we should not let our patient progress more rapidly than these values that you can see over here. So in terms of mean deviation, minus 1.5 to minus 2 decibels per year, more than this or this is way too much. And in terms of FFI or VFI, sorry, then this change is from minus 5 to minus 10% every year. This is clear, but there are other situations in which it's not that easy. And what the concept that's now more implemented is that we have to treat a patient or to do things in our patient, surgery, changes of treatment, being more aggressive, in cases of clinically significant rate of progression. And that means that an amount of loss that could lead to our patient to have an important future visual impairment or blindness in the future. Which factors do we need to take into account? Age, in terms of life expectancy, how the severity of the disease. I mean, in a very advanced glaucoma, it's, maybe it's not too fast, but there are very few ganglion cells left, and maybe just a little bit more of loss in the visual field will be way too much. Presence of known risk factors. We know that there are certain glaucomas like pseudoexfoliative glaucoma maybe that progress really fast, or as we said in a previous example, like African descent also progress fast. And also depending on the quality of life and on the everyday activities of our patient. All of this has to be taken into account. And maybe there are some patients that are progressing who glaucoma is a progressive disease. So our idea is to, live with progression. Maybe it progresses a little bit. It's okay if it's not too much to impair their life. That's the idea that we have currently. And I have one example here. For example, this patient, she's a 79-year-old female. She's now in 3 drugs. And we're thinking, should we operate her or not? We see that there's a trend. It's not like a super big slope. It looks like not too big. But when we take a look at actually to the rate of progression, it's minus 3.4% year, which, as we said here, it's not that much, right? So maybe in this patient, we could wait, but we will need to talk to her. Also, remember these changes in the central field, that also, this capacity to split fixation also needs to take into account. But my recommendation is to take a look to these numbers, because sometimes we just look, this is a slope and it's significant and that's it. And we need to understand what these numbers mean. And the other thing that we need to change in our minds is that Humphrey visual field assessment is not static anymore. It should be dynamic. And now with the new softwares, we can interact with data. That means we can exclude those tests that are not reliable enough. As I said before, VFI and MD are now available, but they are also available as a trend analysis. So it's important for us because sometimes the percentages, VFI sometimes is more difficult to see as a progression, and decibels sometimes sound better, but you can choose, so it's good. And then we can also now put the clinical events that for us are important, for example, a change of treatment, a surgery, something that happened that we want to have in the same graph. And also we can now have dual baselines, which is good because prior to this, you could go inside the Humphrey, you could go to the machine and exclude those tests, for example, that were done before your intervention. But then you were losing some information. And I have an example for this. This is a patient with a pseudoexfoliative glaucoma. He was not very compliant, and he came for some time, and then he didn't come anymore, and then he came again, and we were seeing a really fast progression. At this point, we did surgery, and then we can see how the curve starts to flatten, right? But we could improve these outcomes. How can we do this in terms of, for us, for understanding? Because now we have here a -2 decibels per year loss, approximately. But this is not true. Possibly was true here, but maybe here is not anymore. So this somehow interferes in the whole mean of the evaluation. So what we can do now is to first put here that we did surgery, exactly in what time of this graph, at what moment of this longitudinal data we performed the surgery. And we also can change to have a dual baseline. So we have these two first tests as the first baseline, which is this -2 decibels that I was talking about. And after surgery, we can set then another baseline and have a second trend, which is now a lot less, -0.1 decibels per year. That is very helpful because we can see very graphically how our surgery was able to flatten progression. And again, not only function is important, it's also important to assess structure over time. And we need to understand or have some ideas of how to assess OCT changes over time. The most used parameter, again, would be retinal nerve fiber layer. It has very high sensitivity and is very good for this. It's very useful, again, in early glaucomas, but not so much in advanced glaucomas. And that's because of the floor effect that I was talking about. It approximately happens around 50 to 60 microns, that after that, below that, it doesn't have more range, it doesn't go lower than that. You can be progressing and it will be forever like this. The significant amount of change in terms of peripapillar retinal nerve fiber layer would be 5 microns. Less than this is possibly variability of the measurements. These numbers change depending on the region, but I typically try to understand that 5 microns is the number that I like to have in mind. So the change related to aging, it would be, again, this 0.5 microns. So my way of remembering is that age would explain 5 microns in 10 years. And the significant amount of change is, again, 5 microns. That's how I remember. But we have to be very careful with slopes in terms of structure. And this is different from the GPA of the visual field that we are all used to. In the case of OCT, the slopes are not corrected by age. So if we only take into account that the slope is significant, we will have a high rate of false positives. Actually, this study is very good showing this. And if we use just the idea of slope and we wait the enough time, just because of aging, almost 100% of our patients would progress. So what we now consider is the lower limit of these changes. And what we consider clinically significant would be a rate of structural progression faster than -1 micron per year. For example, showing these ideas of progression, this is a 53-year-old female. We have done multiple changes of drops, adding drops. Now she's still not well controlled. She's 22. Should we do surgery? Well, if we look at the fields are not too bad, because it's a very early glaucoma, almost no damage in the field, in a specific points here that they disappear later on. Maybe here we start to see some focal changes, but this is very stable, or it looks not too bad, right? But when we look at the structure, because this is an early glaucoma, so the structure will help us more, we see that it's actually losing a lot it's like -3 microns every year. We said that more than 1 is way too much. And again, even focally, this is very, very graphically, you can see it easily, it's losing superior and inferiorly. So definitely we need to do something with our patient. The other structure that we can also see over time, and this is sometimes dismissed because the retinal nerve fiber layer is used so much that we sometimes do not use the ganglion cell layer in progression that much, and that's an idea that it's currently changing, is that although it has overall less sensitivity, that retinal nerve fiber layer, to detect progression, it's a lot better than retinal nerve fiber layer to evaluate progression in those cases in which that floor effect that I was talking about has happened. So in advanced glaucoma, it still has the possibility to detect some structural change, and that helps. The same parameters that I was talking about in the previous slide, for the ganglion cell layer, the significant amount of change exceeding variability would be -4, a change of 4 microns. And the same numbers related to aging would be around -0.32 microns per year. That would be aging. That's not pathological. And how does that help us? This is a 75-year-old male. He already has had surgery. Pressures were good at the beginning. Now they're starting to climb, but the fields are not too bad. It looks like, he has a very advanced glaucoma, almost no superior field, but they look stable. They don't look like progressing too much. And if we take a look to the optic nerve, retinal nerve fiber layer, we see again that it's flat, no changes because it's in the floor effect. This is an advanced glaucoma, What happens to the ganglion cell layer? Well, it started pretty well, but now it's starting to change. And actually in the workplace, we can see very nicely all these together. So here we have the fields. Here we have the retinal nerve fiber layer that it's not changing because it's in the floor effect. And if we go we scroll down, then we see the ganglion cell layer. And we see this trend, but we see also how, despite the fields do not look like progressing, and because the floor effect of the structure, we could be missing that actually the patient is progressing in the center, in the macula with the ganglion cell layer. So it's good in advanced patients to also look at structure. Despite the field sometimes give us a lot of information, sometimes the structure still changes earlier. So it's good, again, to assess everything together. And the final point is just some slides about new technologies like the OCT angiography. And, this is like the chicken and the egg with the vascular dysfunction and glaucoma. We don't know what happens first, but there are some studies showing interesting results, like, for example, saying that possibly OCT angiography could have a better structure and function relationship because the OCT angiography, in terms of vessel density, has a less floor effect than the structure. So RNFL has a floor effect. OCT-A has a less floor effect. So possibly that's why the correlation is better in OCT-A with higher R2 values. There are also interesting results in early glaucoma. There are small studies, so we need further evidence to say this. But interestingly, in some studies with preperimetrical glaucoma and controls, they found that the density of the vessels around the papilla had a highest sensitivity and specificity detecting early glaucoma when compared to retinal nerve fiber layer around the papilla. That's very interesting. This was also found in a different study with 33 eyes in the contralateral eyes of the other eye being glaucomatous and controls, and they found again that the OCT-A around the disc and in the disc could detect with better outcomes changes in structure compared to, or early glaucoma compared to structure. That could be a sign of sick cells, but maybe it could be that before thinning, they change things in flow or in density of vessels, but we don't know because this technology has still some limitations. Artifacts, movements, shadowing, projections of the big vessels that the new segmentations will need to address. Also in terms of other diseases, like for example, AMD, it's not able to detect leakage as well as angiography, maybe. Also, we will see with new technologies that go deep in the nerve, but with the current technology, we cannot see very well retrovalvular vessels, so we don't know if only the superficial vessels are involved or maybe the more profound vessels are involved as well. Necessarily, the patient needs to be sitting down. Other previous technologies like echo Doppler could be done in a supine position. It actually needs a very good collaboration of the patients. If it moves a little bit, then you see this motion artifact and all the parameters change. And we don't have still a normative database to actually have a good comparator and see if this patient in this area has a significant change or not. But still, I have some examples because this is for me promising and it has limitations, but we need to study more. I have this 76-year-old patient. He has an advanced ileus-foliative glaucoma in the right eye. And we know that for sure because all matches, right? The nerve, the macula, the fibers, and the field, all matches here, easy. But how about the other eye? Let's see the other eye. Is he starting something in the other eye? Well, we see some points here, but this is very inspecific. Again, let's go to our 1, 2, 3 idea. The nerve looks not too bad. Actually, we have the parameters here and they are all okay. The retinal nerve fiber layer, again, is between normal limits. Maybe it's just that he's not doing the field well, although it's reliable, but maybe it's just a first field, something like this. We did a OCT angiography. Look how different the eyes look. This is the very advanced eye. I have put here the field for you so you can see. And actually, there's no microvasculature. It's all gone. It's all black, right? And here in the other eye, it's interesting to see that we see very well all this vasculature here, inferiorly and all in these areas. But here superiorly, there's possibly an area that could match those inferior points that we were seeing. And this was only a hypothesis. But we then repeat later on the test. And what had happened is that actually that superior area that we were seeing in the OCT-A, actually now the patient had a thinning of that area in structure. So who knows, maybe it's true that we can see vessels. This is only one case. This is just for discussion to have it in mind. But again, there are not conclusive studies about this. So just as a summary and conclusion, the take-home messages that I would like you to have is that it's important to combine all parameters in terms of structure to evaluate the neuropathy as a whole, rim, peripapillary nerve, retinal nerve layer, and the ganglion cells. Remember that 24-2 could underestimate the central points, and that more and more we are using complementary 10-2. That structure and function relationship depends on glaucoma severity. In early glaucoma, OCT works better. In advanced glaucoma, visual field works better. That it's important to assess a clinically significant rate of progression, that it's known in fields that a fast progressor would be when it exceeds minus 1.5 to minus 2 decibels per year, or a change in VFI greater than minus 5 to minus 10%. Although there are other risk factors, and conditions of the patient, age and life expectancy that we also need to take into account. In OCT, those changes would be clinically significant if they are greater than minus 1 micron every year. And that there are new technologies like OCT-A that are promising, but that they still have important limitations. And well, that's all. It's been a pleasure for me to be here today with you. Please do not hesitate to make questions. And I only, because of the difficult times we're living, I just wanted to, in any phase you are, in whatever phase or way your country is, I'm just wishing you strength and the best for all of you, and please take care.